Good morning. It's Dr. John Bennett broadcasting from Miami as part of the conference or the collaboration of Neurosurgical TV with Deepak Gupta of the Neurosurgical Department of the AIIMS Hospital in New Delhi. We have the pleasure today of having Subodh Raju. I hope I pronounced that correctly. He's going to talk about surgical. Oh, thank you. We'll talk about surgical options in craniosynostosis.
Yeah.
And let me introduce members of the panel first, Subodh, before I turn it over to you. Good day, Francesca.
Yes.
Hold on. We've got to introduce the panel first, Subodh.
Okay, yes, good morning. I'm Francesca Occhia. I'm a fifth-year medical student from Bucharest, Romania, and also the president of the Walter Dandy Neurosurgical Club for medical students here. And I am really honored to be part of this first online pediatric neurosurgery conference. I think it's a great initiative, and I'm looking forward to the presentation. Thank you.
Yes, and the doctor assembled the cast, Dr. Gupta. Good morning, Dr. Gupta.
Good morning, and I look forward to your talk, Dr. Subodh Raju.
Yeah, I'm ready to start, John.
Yes, okay, welcome.
Okay, I am on with a presentation.
Yes, could you please introduce yourself, where you work and what you do, etc.?
John, I'm Dr. Subodh Raju. I am basically a neurosurgeon passed out from AIIMS, All India Institute, 15 years into practice, and 40 to 50% of my work is related to pediatric neurosurgery, and that's how I'm into these issues. And 1 minute, I think I lost. And I do a host of pediatric neurosurgery cases, including craniosynostosis, dysraphism, and a lot of endoscopic work I do, actually. And keep on doing some publications, some research in pediatric neurosurgery, because that is part of my passion. And maybe down the line, I may become a pure pediatric neurosurgeon down the line.
Oh, excellent. You're talking to a future one to your right, and Francesca wants to be a pediatric neurosurgeon too.
Absolutely, absolutely.
Okay, welcome. Okay, onward.
Right. Am I on?
Yes, perfect.
Presentation is on?
Yes, it is.
Okay. Good morning, everyone. Good morning, friends. And it's a present day in India today, no rains. And what I am going to deal, first of all, I should thank John and Deepak for taking this initiative. What I am going to talk about is surgical options in craniosynostosis. Because there are two other talks lined up in craniosynostosis, I will restrict myself to non-syndromic primary craniosynostosis. These are my affiliate hospital, Virinchi Hospital and Rainbow Children's Hospital. Some disclaimer and acknowledgement, because in these cases I have used a lot of photographs. So I would like to say that these photographs are used only purely for academic purpose. And actually I thank my patients and attendants for helping us in advancing and disseminating. I mean, they contribute a lot in disseminating the medical and surgical knowledge for the future of medical science. I am thankful to them also. Coming to the introduction, because I have the first talk, I'll give a brief introduction of craniosynostosis. The term craniosynostosis refers to premature fusion or multiple cranial sutures. Craniosynostosis is commonly present at birth, but is not always noticeable, especially when mild. And apart from the obvious cosmetic and facial cranial deformity, early cochlear sutures can cause intracranial hypertension and adversely affect the development in some patients. And if we know, it is one of the major causes of a cranial dysmorphia. So normal infant skull is flexible and expansible. Flexible enough to get through the vagina in a normal delivery, and expansible enough to accommodate the rapidly growing brain. So there are different theories which have been proposed for the formation of craniosynostosis, starting from Sommering in 1839. Then Virchow and the Moss theory. I'll come a bit into it in detail actually. So Moss tells that it is basically the cranial base which is primarily the abnormality, and the cranial vault suture abnormality develops second to the base abnormality actually. And the functional matrix theory which he proposed was whenever there is a functional enlargement of the brain, and that is a primary force for causing the expansion of the skull and for changing the shape and determining the final form actually in craniosynostosis. If you look at this, growth is always perpendicular to the suture, and whenever there is an ossification is occurring, there is bony union occurring. That restricts the growth of this skull actually. And early closure causes growth parallel to the suture. So instead of having a perpendicular growth, we have something called as a parallel growth, and that causes the abnormal shapes. As the most commonly what we see is a sagittal synostosis or scephocephali. I mean, for general purpose, explaining everyone, there's a commonest craniosynostosis which we see.
Excuse me, Subodh. Your slides aren't moving. You still want to be on the first slide?
I'm moving. My slides are moving here.
No, the slide. Okay, there you go. There you go. Okay.
Okay, I'll go out from the presentation mode. I'll put it in this only.
Okay, no, you have to click on the slides, each one individually.
Yeah. Now you can see it?
Yes. Okay, please check with me if you change the slide to make sure.
Okay.
Okay.
It's okay?
Yes.
Okay.
Yes. Molecular factors? Yes.
Yes, correct. So there are a number of molecular factors which have been implicated in the formation of craniosynostosis, fibroblast growth factor, TGF-beta, twist, noggin, so many things have been seen. And most of these factors are usually seen in syndromic cases than in non-syndromic cases actually. And there is no consistent gene abnormality associated with a specific phenotype basically. So possibly we feel that the formation of a craniosynostosis is multifactorial, especially in non-syndromic cases. The physical and molecular factors along with the genetic pathways which are also responsible for this actually. Incidence is 1 in 2,500 live births. So the commonest, as I told you, is the sagittal synostosis, and syndromic types are less common, and there have been more than 64 syndromes have been described due to more generalized disorders of the mesenchymal development. Coming to a brief classification, we classify synostosis into primary and secondary syndromic, and primary can be a simple when it is single suture involvement, and it's compound when it is a multiple suture involvement. Then secondary, we have a host of metabolic factors. Then we have the syndromic. Dr. Dwarka later on will be covering on the syndromic craniosynostosis. Coming to the primary, this is the normal skull actually which you see. Then we have the metopic suture where we confirm the trigonocephaly. Then we have the brachycephaly, unilateral coronal suture. There's the anteroplagiocephaly. The unilateral lambdoid suture, we call it the posterior-plagiocephaly. And whenever we have a fusion of both the sutures, then we form as a scephocephaly. So what about the secondary craniosynostosis? When does it occur? It's usually seen microcephaly, prematurity, VP shunting, and positioning. Positioning is also one of the important cause of these thing of secondary craniosynostosis. Prematurity because of deformation of scephocephaly. There's an impaired mobility and prolonged positioning of these kids, small infants actually, and these usually continue to persist till adulthood. And they usually don't warrant any intervention. VP shunting. Whenever there is a hydrocephalus, especially in early life in premature children, we do a shunt that causes a secondary craniosynostosis actually. In microcephaly, surgical correction is not indicated. We may have an abnormal OFC, but it remains normal, yet it is oddly shaped. Rare cases of multisutural craniosynostosis restricting head growth may manifest with increased rise of intracranial pressure. These are the cases you require surgical interventions actually. The positional deformation, as I told, is the most common cause, usually a forehead asymmetry, sometimes associated with torticollis, and usually acts as in coronal and the lambdoid sutures. And it is, as I told you, it is seen in usually premature newborns actually. Multisuture non-syndromic double suture, then there are the complex multisuture synostosis. There are some examples of a scephocephaly, early fusion of the sagittal suture. Then we have the anterior plagiocephaly, unilateral coronal synostosis, and a posterior plagiocephaly, a unilateral lambdoid suture. Then we have the brachycephaly when there is a bilateral coronal suture fusion. And when we have a trigonocephaly or the conical head, we call it, there's an early fusion of the metopic sutures. Syndromic craniosynostosis, I just run through it because Dwarka is going to deal with it. Actually, 10 to 20% of cases, they are autosomal dominant. The commonest are the Cruzon, Appert, Carpenter, Pfeiffer, and Chosen. Some examples, these are some of my things. Apperts, I'll not go into the details of this. It is for completion's sake I have put this, and then the Carpenter syndrome. Secondary, we have host of storage disorders, metabolic disorders, hematological disorders, and drug-related secondary craniosynostosis actually. So how do these present, this craniosynostosis? The usual presentation when they go to a primary pediatrician is usually a cosmetic reason. And in severe cases, they can have a mental retardation. We have a raise in intracranial pressure, or they can present with visual abnormalities. So what is the mechanism to affect the development of the brain? There is global intracranial hypertension, focal brain, hypoperfusion may occur, and mechanical deformation of the neuroanatomical structures can cause this mental retardation. The more common in syndromic metabolic this mental retardation, and it is, as I told you, it can be due to cerebral atrophy, hydrocephalus, infection, intracranial abnormalities, associated abnormalities, and if there is a family history of mental retardation. Mental retardation in single suture synostosis is due to primary brain malformation than actually due to the distortion of the skull. But there is some interesting study which came out way back in Journal of Pediatrics. It has come Pediatric Physiology. It has told that a single suture craniosynostosis is a review of neurobehavioral research and theory. It has told that isolated craniosynostosis is associated with 3 to 5-fold increase in risk of cognitive defects or learning and language disability. But they could not establish a cause-effect relationship on this. But there was no particular calvareal suture which they could associate it. So there is a very little evidence for quasi-experimental studies that cranioplastic surgery prevents or reduces the risk of neurobehavioral ailment. But this association was seen actually, and that is substantiated by the number of publications which we have on neurodevelopmental outcome in craniosynostosis. Then next comes the visual abnormality actually. Optic atrophy, a primary optic atrophy if there is a skull-based synostosis or early fusion which is occurring, or a secondary due to papilledema, or it's more common with multisutural craniosynostosis. It occurs by a bony compression or because of the carotid vessels or increased ICP. And in single suture synostosis, usually the visual symptoms are less common. These things. Raised ICP, another feature most common in syndromic, rarely seen in single suture. And there is evidence that whenever you do a cranioplastic surgery, there is a decrease in ICP. Detailed examination is very important, including the shape and the head circumference, everything we measure, and ear and facial abnormalities. We palpate the suture lines and frontally. If it is early, sometimes you do not do a CT scan also. A high definition ultrasound is sufficient to diagnose a case of synostosis. And we have to always look at the hands and feet and look for other associated anomalies. And a routine neurodevelopmental assessment is done in our place, and ophthalmology assessment is mandatory in all these patients. Whenever there is required, a 3D CT head with recon and a skull X-ray is always done in these cases. So what are the issues actually in craniosynostosis? Single suture craniosynostosis is associated with neurobehavioral problem, including learning disabilities and behavioral problem. The causal relationship between this condition is uncertain actually. A calvareal abnormality is at the least visible and easily diagnosed marker for elevated risk of neurodevelopmental problem. So the calvareal problem or the facial dysmorphia or the cranial dysmorphia gives an indicator that these children have to be evaluated in detail, have to be evaluated properly by a neuropsychologist, a pediatric neuropsychologist, and see for any developmental anomaly. Similarly, an ophthalmology evaluation is mandatory. Next comes the decision to operate. So raised ICP is seen in 1/3 of cases, but there is no neuro impairment in these cases. The most important part is the cosmetic consideration, usually most important. So this cosmetic deformity, a child when he's small, he cannot complain that I've got an abnormal feature, abnormal suture. It's a parent's responsibility to take care of that. So this affects the peer acceptance, parent-child bonding, and the self-image and the self-confidence of the child is also affected. The possible of future neuropsychological and educational problems and an unusual head shape can have a profound effect on the child's personality, self-esteem, and social interaction as the child grows up. So these things in a present-day scenario, cosmetic considerations also carry an equally important place as a neurodevelopmental raised ICP. The cranial vault remodeling is the typically recommended treatment. The goal of the treatment is to reduce the pressure in the head and correct the deformities of the face and skull bones. Timing of surgery. So normal growth of skull tend towards increasing roundness in the first year of life. Clinical studies say that more significant improvement if done before the first 6 months, between 6 months, because the first phase of the maximum brain growth occurs between 3 to 6 months. So if we can intervene before that, then it's easy. And the correction of the cranial base is more successful if it is done early. Advantages of early repair is remodeling is easier because the bone is very malleable, and the rapid brain growth benefits the bone remodeling, and there's bone defects which we create by the surgery and these things heal rapidly. So as this graph shows with increasing age, what are the surgical intervention we do? The initial part when we do a non-restrictive bone fixation, then comes the blending techniques, and as the child grows in age, we have to go in for more and more rigid fixation. Sagittal synostosis, I'll quote some few examples down the line about individual suture synostosis and what are the surgical strategies described in book. Most of this thing I've taken it from the pediatric neurosurgery book and the neurosurgery textbook by Yeomans actually, and then what I do also. Some of them I have included in this. So this is the most common form of synostosis. Incidence is 2 in 1,000 live births. 80% are sporadic. And there's a frontal compensatory boson. We have an elongated boat-shaped head. And the anterior frontal and posterior frontal are closed. And the surgery, when it comes to, if it is diagnosed early, we can do an endoscopic assisted strip cranectomy, assisted procedures, followed by a helmet therapy, or we have the whole plethora of surgical excision of the sagittal stosis, remodeling of the parietal bone, the occipital bone, and the frontal bone. So earlier the surgery, better is the results in these cases actually. So endoscopic treatment, underlying principles of endoscopy. Endoscopic treatment is not basically an endoscopic treatment, it's an endoscopic assisted surgery, and operating on very young infants, less than 3 months of age. And this allows the rapid brain growth to correct the pre-surgical deformities. I'll show you some examples down the line actually. And post-operative helmets to aid and achieve correct symmetry. The use of helmets, there is a limitations in India because we don't get the manufacturers to make this particular type of helmets, and whatever helmets which are available are highly expensive for any common man to make it. So at my institute, I have made some low-cost helmets which hardly cost maybe $10 to $20 actually, compared to the $700 helmets which are standardly available in the international market. Coming to the some review on the outcome of endoscopic suturectomy with postoperative helmet therapy in bilateral craniosynostosis has been Proctor has from Boston Children's Hospital. Actually, I had the opportunity to work with him for some time, so I see him doing a lot of this endoscopic suturectomy. But lucky that he gets all his patients before 4 months of age actually, and because it has a shorter hospital stay, early recovery, then the helmet therapy is started. Sagittal synostosis can be safely treated with endoscopic suturectomy and helmet therapy, and improvement in cranial volume and shape are comparable to open procedures and are enduring actually. So what we do is a strip cranectomy, which has been traditionally described. So that has been only incorporated now. Actually, these are some of the cuts which we make sagittal endoscopically. We can make these cuts actually. This is a 3-month-old child who presented luckily to me with at 3 months of age, and I thought that this child is suited for a sagittal strip cranectomy. You can see the fused sagittal suture here and elongated boat-shaped head, what we classically describe. But the thing you can see here is the frontal thing is normal here in this child. So we don't have to do a frontal limiting. So it was a pure sagittal synostosis only. So I think if my video plays, you can show. It's loading. So we make basically two small incisions here in the front and the back actually, and pass the endoscope. My video doesn't play now. And from the one end we pass the endoscope, and from the other end we pass the instruments, and under the guidance of the endoscope, because we are operating on the sinus actually. So the endoscope helps us in guiding us through this cranectomy, and we remove a strip of the bone from there, close the suture, put a small drain, and the second day first day or second day the child goes home actually. And I think my video doesn't play. Okay, no problem. So this is a low cost helmet. I told you it costs around 700 rupees or something like a 10 to $20 actually. So this was the pre-operative which we had done actually, and this is the post-operative. We can see there's a correction in the shape of head. The child required a helmet pay only for at least I think next 6 months only. After that it didn't require anything actually, and the child is developmentally doing well actually. So these are the things which, because again referring this children don't come to us usually early, because they land up in the primary pediatrician. The primary pediatrician feels there's an abnormal shape, and they continue to manage that, and they usually present us late. So if you're lucky enough to get some of these children early, then we can be very helpful by doing a minimal access surgery followed by this low cost helmet therapy. And I have used it in 7-8 cases. They have been doing well, and hope to get it standardized and see if I can put it in India and sometime down the line actually. This was in a review article by Dr. Proctor actually, and where he has emphasized the importance of endoscopic techniques in this craniosynostosis who present early. And the advantage, what they do is they don't do a scan actually, they use a 3D laser scan actually in these type of children. So the patient is basically not exposed to any radiation actually. So advantage of the helmet is that it allows to growth in a 3-dimensional fashion and can be modified over time to achieve the specific correction in certain areas and does not require any further surgeries. Limitations of the helmet include need to wear the helmet, the need to adjust the helmet on a regular basis, generally every 2 to 4 weeks intervals they have to be adjusted. And the family is generally counseled that helmet therapy might be necessary up to 1 year of age actually. These helmets actually, what happens in tropical countries like India, because there is a lot of heat and these things, the children get irritated by this helmet. So that is also one of the limiting factors in use of these helmets in tropical countries. We have to make some country-specific helmets down the line. The benefits of minimal invasive surgery include much shorter surgical times, much less blood loss, and a very, very small, nearly invisible incision is there actually. And the parents are very happy. These are some other examples of helmet. Actually, this child managed to get a helmet from US by doing a scan. I mean, not everyone can do it actually. So this is another case of craniosynostosis. Then comes to when the child grows older, more than 4 months or 6 months of age. What do we do? So a section of the skull is removed as a Greek letter that's called as an anterior pie procedure or a posterior pie procedure. Depending on the requirement and depending on the shape of the skull, we do it actually. So this is again a case of a scaphocephaly. This child has both a sagittal and a metopic synostosis. You can see elongated head, a frontal bossing, and this age of presentation was 7 months actually. This is a non-syndromic child. This is a CT scan of the child. You can see some of this silver beaten appearance of the skull because of the raised pressure. As I told you, we do a routine ophthalmological evaluation and a developmental assessment in all these children actually. So this child went ahead with an anterior pie procedure, you can see here, and biparietal release, front orbital advancement, the remodeling of the frontal bone, which is done. I'll tell you subsequently how we do remodel the frontal bones to create the frontal eminences, especially when the scaphocephaly, the sagittal synostosis is associated with the metopic synostosis also. You have to take care of the frontal bones also in those cases. This is the pre-op, after the scalp has been everted, you can see the metopic is also fused actually. This child has been operated in a supine position because the child didn't have any posterior problem. So it's only an anterior pie procedure, what we call it actually. These are the post-op images. This is, you can see, this is the pre-op image of the child. This is, the child is growing out to be a beautiful kid. Nice, developmentally absolutely normal and doing well. So standard technique plus frontal remodeling is what we do advise if the child is more than 10 months old and there is severe anterior bulging. So this is another child with the same, this child didn't have a frontal problem. The child only has a sagittal synostosis but presented to us late. In that case, what do we do? Sorry, I missed one slide. Yeah, this is the operative photograph of these things, a biparietal release, a frontal these things. And in cases, we can remove this strip of bone actually, but we have to be careful when we are removing the sagittal, take care of the sagittal sinuses. And advantage of keeping the pericranium intact, we cover it over there, that helps in also osteogenesis. The pericranium has a greater role in this. But two things are there. Whenever you are doing a smaller procedure and you anticipate a lot of blood loss, you can excise the bone along with the pericranium also. So if you don't strip off the pericranium from the bone, your blood loss is minimized by more than 70 ml actually. But pericranium has its role, everyone knows. So it all depends on how experienced you are and how familiar you are while doing the craniotomy, whether you want to strip off the pericranium or you want to leave the pericranium intact on that actually. So that's an individual choice, but this is the difference which I have seen I had done this in around 10 cases without stripping and with stripping, where I found out the blood loss to be around 70 to 75 ml less if I am not stripping off the pericranium from the bone. Then comes a child who is older, 12 to 14 months. Complete calvareal reconstruction is required in these cases, and there is a severe cranial base distortion. It's a more aggressive technique. Important thing in all these children is, one is blood loss, second is venous embolism. This is the most important thing which has to be taken care of. It has been reported to be, incidence of venous embolism has been reported to be around 20 to 25% in cases of craniosynostosis surgery. So the anesthetist, the surgeon, everyone has to be aware of this, and you have to coagulate it every small vein, and whenever there is a bleeding, please stop it. And a continuous irrigation and putting on moist cotton patties everywhere, wherever is your exposed portion. And patient should not develop, most important, patient should not develop hypotension due to blood loss. So the blood transfusion in these cases has to start with the skin incision only. Because the moment the child develops a hypotension or there is a blood loss, there's a negative venous pressure is low, it sucks in air actually. So that is very important, has to be careful. In my case of around 75 cases, I lost one child, actually a syndromic child, on table due to a venous air embolism actually. So this has to be very, very careful. Actually, I should have put that into. Next comes the coronal synostosis. It's the most, the described thing is a sagittal, but what we see more and more children presented with coronal synostosis, that's a unilateral coronal synostosis called as a plagiocephaly. Most cases are sporadic, and unilateral coronal synostosis occur with synostosis of the frontospinoidal and frontoethmoidal bone. Manifest as a progressive cranial, orbital, and facial asymmetry, and we get something called as a facial scoliosis. This is a unilateral coronal synostosis, a CT scan of the patient. The one side coronal suture is fused here. The fused suture, flattening of the ipsilateral frontal bone, bulging of the ipsilateral squamous temporal and contralateral frontal bone, and the ipsilateral ear is fused to the suture, displaced, and it's displaced anteriorly. The important thing is to make aware the neurosurgeons, pediatric neurosurgeons, and the pediatrician that how to differentiate between a deformational versus a plagiocephaly actually. In infants with position head deformity, the ear migrates anteriorly and the forehead protrudes on the side of the occipital flattening. So I'll go to the difference actually. This is a very important slide actually for, I keep on telling to my colleagues and the pediatrician how to differentiate this, because many times a unilateral craniosynostosis is left as a deformation and no intervention is done actually. So these some of the differences which are standardly available in every textbook if you see. Yes. What we do is bicoronal flap, a bifrontal craniotomy, a orbital roof. Hello? A lot of disturbance. Bicoronal flap, bifrontal craniotomy, orbital roof osteotomy extending to the frontozygomatic suture laterally to the midline. And ipsilateral superior orbitorium is contoured by drilling to equalize the mediolateral dimension of the orbit actually. So this is the thing which you do actually. Once you do a frontoorbital these things, the V-shaped on this thing is corrected to match the opposite side. This is a small example. This child presented quite late, 16 months of age, non-syndromic, developmental milestones were normal. But later on we find out that this child has a speech delay. This child has a left-sided plagiocephaly. And I covered the eyes, but if you see, this is called as a facial scoliosis. This bend of the nose and this thing from the forehead, this is called as a facial scoliosis. And they have a tilt. So whenever the child has a tilt, the skull base has to be evaluated properly. This tilt can be because of two reasons. Either there is a condylar hypoplasia, of unilateral condylar hypoplasia, or because of this plagiocephaly, they develop a small squint, and by compensation, by compensation to make the visual field normal, they usually tilt the head. So it's an anatomical problem or a functional problem that has to be seen, always evaluated pre-surgically, because and sometimes these persist after surgery also. So if there is no anatomical abnormality in the condyles and anything, you have to just gently relaxed the sternocleidomastoid and asked to do some physiotherapy. Sometimes a passive orthosis is also required to make this correction head. This is a CT scan of a child, the same child. You can see a unilateral coronal synostosis, the plagiocephaly. The brain looks quite tight here. The CSS spaces are obliterated in this case. This is the case where we do a bifrontal orbital craniotomy, left frontal orbital advancement, and contouring of the frontal bones. The frontal bone is contoured by putting multiple radial incisions so as to create a new frontal eminence for the child. This is the preoperative, this is the 6 months post-op, and this is the 12 months post-op. A small tilt still remains in this child, but it's fine. Cosmetically, she is good, and she is now almost 8 years old, 8 or 9 years old. She's going up to a beautiful girl. These are some other cases where I was talking of the frontal bone remodeling, which I observed. You put multiple radial incisions on that. This is showing us text. Yeah, this is another child, left anterior plagiocephaly. You can see this. This is a pre-op picture. This is the post-op picture of the child. This is another. There are two techniques of doing this, left and anterior plagiocephaly. One is the thing which I described, where you do a frontal orbital, unilateral frontal orbital advancement, and usually we tend to overcorrect slightly in these patients because there is some settling down. So 20 to 30% overcorrection is always mandated in this plagiocephaly. This is a second type of thing which we do. That is called as we rotate the frontal bone actually, keeping this intact. I think if you can go to the presentation view, I can show you, but that's not playing. So here is a frontal bone. The midline has been rotated slightly. The excess bone in cut is one side and put on the other side. After this rotation is done, then what we do is we remodel the frontal bone by giving multiple radial incisions and plicating the frontal bone by 28 gauge stainless steel wire so as to create good frontal eminences on that side actually. So these are the two techniques which are standardly described for managing these plagiocephalies. One is rotation of the flap, another is remodeling of the bone by just doing a frontal orbital advancement. The next comes the endoscopic technique. Again, at less than 3-month-old child, you can do a simple suturectomy in these cases. And this is the lesser wing of sphenoid, temporal dura, the frontal dura. Again, if you are lucky to get a child which is less than 3 months of age. Next comes the bilateral coronal synostosis or the brachycephaly. Fused coronal suture. They have a shortened anterocranial fossa. Osteotomies, which we do usually, is a bifrontal craniotomy, biparietal craniotomy, and bilateral supraorbital rim advancement. If I see. One minute, it's not playing. These type of things, again, as I told you, the blood loss and everything has to be careful. This thing presentation has got stuck. Yeah, this is the scan of the child. You can see a flattened head. The bilateral, both the coronal sutures are fused, and this child has a typical silver beaten appearance of the skull. The flat anterior, a tight skull. We do a frontal orbital advancement in these cases. As a frontal eminences are normal in these cases, so you don't have to remodel the frontal bone. You have to just do a frontal orbital advancement and do a biparietal release and just leave it like that. If required, if the posterior part is also flattened, you need to correct. But in this child, if you see, the posterior part is not that abnormal. So we didn't do anything in the posterior part. We just corrected the anterior part. It's a frontal orbital advancement we did only these cases actually. Next, coming to the metopic synostosis, is the first cranial suture to fuse at 7 to 8 months of age. Premature closure results in the typical trigonocephaly, male preponderance, and prominent metopic ridge. This is a commonest complaint with these children come. and some children may have a hypotelorism. So this is the basic sketch diagram depicting what is the problem. Isolated etiology is unknown. It can be part of many syndromes. If child presents early to you, you can do an endoscopic surgery, endoscopic assisted strip craniotomy, or you can do an open surgery. Bifrontal craniotomy, frontal bone remodeling, very important in these cases of trigonocephaly because they have a flat frontal bone. Whenever the frontal bone is flat, only advancement doesn't suffice. You have to remodel to create a frontal eminence in these children actually. And in older than 3 years old, you have to do, as I told you before, in scaphocephaly, you have to do an extensive remodeling of this frontal bone actually, because the bone becomes more and more rigid. There's the pre-op images of the child, triangular head, conical head. This is the frontal bone which has been straightened by this method. You can see it's a triangular bone. We do an osteotomy here, put a piece of bone graft, and in some cases I use bioabsorbable plates or we use a small titanium. The rigid fixation is usually required in the base of the skull only. The other parts of the skull can be managed by simple sutures. But I feel that the base of the skull, rigid fixation is always helpful so that it acts as a scaffold to other bones to settle and the shape comes good actually. But the problem in India is again, the bioabsorbable plates which are available are quite expensive actually. And we can use it, we use it limitedly and sparingly actually, the bioabsorbable plates. So to optimize that, what I do is that I only use this bioabsorbable plates on the base only. I don't try to use those plates above. So to bring down the cost. And if it is not available, we use the small titanium mini plates actually. Or put a bone graft and just put ethylon sutures. This is the thing which I was explaining about frontal bone remodeling. Take the frontal bone, we make multiple radial cuts into that. Okay, once you make this radial cuts, take a fine stainless steel wire and plicate that. So if you do a circumferential plication of this frontal eminence is created. So after surgery, it gives a very good cosmetic result actually. If you add on to all your plagiocephaly and the trigonocephaly, it gives a very good feature. So these radial cuts are useful in both circumstances. Whenever you want to plicate it and form a frontal eminence, or whenever you want to flatten the bone also, these multiple radial cuts are also very useful. So they can be used in either ways depending on the requirement actually. So this is the child post-op. You can see the good frontal eminences which has come up. This is the pre-op image. This is a post-op image actually. This is early post-op image. This is a late post-op image. Good frontal eminences come up actually. So this is things, if you keep on doing it, you will know where and when it's required. This is another child, same with the trigonocephaly. You can see the conical head here and this child in the post-op period. Endoscopic, as I told you, if indicated, if you get a proper child and these things, and you can have an helmet given to the child. These children don't require helmet for a long time. 3 to 4 months of helmet therapy is sufficient for these children actually. Next comes the lambdoid synostosis, extremely uncommon, and it's the least common actually. And distinction is important again to deformation and true synostosis. And most common cause usually forehead asymmetry, sometimes associated with torticollis, and 40% of these things are seen in newborn actually. This is again a differentiating the diagnosis of posterior plagiocephaly, how to differentiate it actually. This is an occipital. This is basically a parietal this thing, frontal bossing, ipsilateral, contralateral. The more important thing, when you take the head shape, when you look at superior view, when you take a vertex view, this is a deformation is basically a parallelogram, but this is a trapezium. When you took a posterior view, it's normal, but this one is a parallelogram. Again, deformation incidence is more common than the true lambdoid synostosis actually. In deformation, the occipital flattening is there, and suture is open, and frontoparietal blossing is there ipsilateral in deformation actually. So this is what I was trying to tell. In deformation, it's usually a parallelogram, whereas this is a trapezoid actually, in case of a true lambdoid synostosis. Elevation of the skull vertex is important, and here what we do is a biparietal occipital bone flaps, bifrontal symmetry if required, and the bone is recontoured. But it's seldom required. This is a case of a posterior brachycephaly actually. It's not a unilateral, it's a bilateral. This child had a raised ICP with florid papilledema actually. And we saw this child, if you can see, you can appreciate the CT scan, both the lambdoid sutures and these things are fused actually. So this, we operate these children in the prone position. This is another child, interesting child, with sagittal coronal lambdoid synostosis, pan-craniosynostosis actually. So what surgery did we do in this children was a corrective cranioplasty, that's endoscopic we did. This child presented early to us. Just did a sagittal strip cranectomy with biparietal release, coronal release, and lambdoid. So when you do an endoscopic surgery, you can do some dissection also and release it. The only important thing is, you should see that the blood loss has it's not too much adherent. And what happens is the dura comes and protrudes into these bony defects because you see the severe silver bitten and copper bitten appearance of this. So the chances of injuring the dura in severe these cases are high if you try to do an endoscopic surgery. So, and if you do a blind surgery, so endoscopic, a 30-degree or 70-degree endoscope is very, very helpful in these cases if you're trying to do an endoscopic strip cranectomy in these cases actually. This child had a CT scan because of a head injury later on after some days actually. So if you can see, all the silver bitten and copper bitten appearance of the skull has disappeared actually. This is around 8 months after the primary surgery. So this child is doing well actually. This media is not playing. I don't know why videos are not playing. There's another child with a pan-craniosynostosis. This is it looks like a syndromic, but this was a non-syndromic child. This required a two-stage surgery because the bone was very brittle. The child developed pseudomeningocele at one side because of a CSF leak. The child required two surgery, but she has turned out beautiful actually down the line. This is another case of a taricephaly. This child had an optic nerve atrophy and an ACM type 1 with syringomyelia. So surgery, what we do is a corrective cranioplasty with bifrontal coronal lambdoid and parietal release, a sagittal strip cranectomy with a fronto-orbital advancement, and during that surgery, in these cases where there is a primary optic nerve compression because of bony these things, we tend to do optic nerve decompression also in these cases actually. Because once you do a fronto-orbital advancement and you remove that bone, just reflecting in the dura, doing optic nerve decompression is not a very difficult job actually. Coming to craniofacial syndromes, I think Suhas and other people are going to cover it later out down the line. So coming to complications, mortality in craniofacial surgery are fortunately very low. And the most important thing is a postoperative hypothermia. And due to more extensive tissue dissection and requirement of transfusion. Infection is another things. And these all things depends on the age of this child, the type of surgery you are doing, how extensive is the surgery. And they usually require, as I told you, two things when we counsel the children is, with the parents, is one is blood loss and second is infection. And the dural tears, if you have to repair it very meticulously. If required, put a patch and glue it. Because if they continue to have a pseudomeningocele, if they develop a pseudomeningocele, that repairing is another big surgery. So this has to be very careful. If you have an accidental dural tear, it has to be repaired primarily with a patch and glue also, so that they don't have a CSF leak. Ocular morbidity, pre and post-op impairments seen with unilateral coronal synostosis and metopic synostosis, because once we are correcting this anterior plagiocephaly, in the early period, post-op period, these children tend to create of diplopia actually. I mean, they'll not complain of diplopia actually, but they'll be restless whenever they see. So these things have to be evaluated by a pediatric ophthalmologist and they take care, but that usually compensates in another maybe 1 month to 1.5 months. So the pediatric ophthalmologist also is closely involved in our work, and oculoplasty departments sometimes join us in these type of cases whenever there is a base of this thing, because they also give some important inputs in management of these cases. Coming to long-term follow-up, speech, genetic counseling, feeding, swallowing is required. And as I told you, refusion may require redo surgeries. These things also we counsel the parents when you do a primary surgery, that the child may require a resurgery if required. So my first conclusion or summarizing is, the key to treating craniosynostosis is early detection and treatment. That is, increasing the awareness among the primary care physician, that is a pediatrician. At the base level, we have to create an awareness among them actually first. Some forms of craniosynostosis can affect the brain and development of child. The degree of problems is dependent on the severity of the synostosis, the number of sutures that are fused, and the presence of brain or other organ system involvement. Genetic counseling may be recommended by the physician to evaluate the parents of child for any hereditary disorders that may tend to run in families. And a child with craniosynostosis requires frequent medical evaluation to ensure that the skull, facial bones, and brain are developing normally. They have to be under regular follow-up. The medical team works with the child's family to provide education, guidance to improve the health and well-being of the child. And craniosynostosis surgery is basically an art. You have to imagine in the 3D space whenever you are going to operate on these things, and then only you can deliver a very good surgery. And ending, thank you to all my little angels who helped me and who have been operated with me. I must have done around 70 odd surgeries actually of synostosis of different types, and luckily none of them have required a redo surgery till date. Again, thank you. With this, I conclude my talk. John?
Yes, thank you. Thank you very much, Raju, for a great presentation, great illustrations. I just have, Francesca and Deepak, do you have any questions or comments for the doctor?
Yeah. So congratulations, Subodh, for a wonderful cover up on this topic of non-syndromic craniosynostosis. I would like to know in what percentage of cases of non-syndromic variants do you do genetic workup, and how do you counsel the patient's family for the next birth in non-syndromic variants?
Most of this non-syndromic synostosis, a complete evaluation is done. First, we don't do a gene analysis on everything. We have a medical genetics associated with me. She does a thorough morphological and evaluation, everything. If there is no abnormality as such seen, we don't go for a gene analysis in these things. And so no specific genetic counseling is required in those cases. And most of the children, the subsequent sibling or the preceding previous sibling never had a problem in this non-syndromic cases actually. I never had a familiar trait which is running wherein one sibling is affected and the second sibling affected. Yes, but one important thing I've seen is the family, when it comes to the father, to the kid, it's mostly a shape of the head. It is not a synostosis. So many times the abnormal shape of the head is considered as a synostosis, which is actually not actually. And what was the second part of your question?
What do you tell the patient's family? Because the common question asked by the parents is, what is the risk of my second child being affected with the same problem?
I mean, I tell them it's just the incidence is same as the occurrence of a craniosynostosis, the incidence of craniosynostosis. That is 1 in 2,500 live births. That's all.
My second question is regarding the need of fronto-orbital advancements. What is your thought in doing this when the child is relatively young? Let us say you have a child who is 7 or 8 months of age with some hypertelorism or with some frontal bossing and some shallow orbits. Do you go ahead with those fronto-orbital advancement at that age, or do you wait for the child to grow older and then operate? What are your thoughts on that?
For me, a craniosynostosis surgery is best done as early as possible. If you have a safe anesthesia, safe setup, everything is done, the best time is to operate as early as possible. Because as I told you, molding of the bones, the fusion of the bones, healing of the bones is excellent in the small children. If you remove all of the risks, as I'm telling you, the risks of blood loss and these things have to be taken care. Otherwise, you operate it as early as possible.
Thank you. Thank you.
And Francesca, you have a question?
No, I don't have a question. I would only like to congratulate you, doctor, for your wonderful practice and this incredible presentation. Thank you so much.
Thank you.
It has been a great honor and a pleasure.
Thank you very much, Aman.
Yeah, I have a quick question. How do most of these patients get to you? Are they referred from their local pediatricians? I imagine it takes a while for some to be referred, correct?
These patients usually, I do a lot of, as I told you, I'm associated with a pediatric hospital.
Okay.
It's one of the primary, in this state, it is one of the main referral centers in the state. So, and I go and conduct talks, awareness talks in pediatric conferences also. I don't restrict my talks to neurosurgical fraternity or neurology fraternity. Uh, there is another craniosynostosis talk which I have, which is just a general talk to increase the awareness among the pediatrician also. So a small, whenever they have the small meets, the pediatric conferences or meets these things, I give a small talk on increasing the awareness in the primary pediatrician. So over time, what has happened, initially when I started this surgery, maybe 11 years back, I used to operate maybe one case every 2 months or so. But now what has state is I get at least 3 or 4 referrals every month actually. So that is helpful, and at least I'm hopeful for the future that if the awareness is increased, we can get to tell and propagate this early detection, and surgery is helpful.
Yeah, as I mentioned in our previous talk, this platform is a great way for pediatric neurosurgeons to meet with pediatricians online and have conferences and be able to spread the word and actually get to these patients quickly. Because in medicine, like anything, the quicker you get to the patient, the better. So, okay, very good. I'd like to thank you, Doc, for a great presentation, for taking the time and your dedication in your career. And we welcome
Thank you very much.
We welcome you to participate in as many of these conferences as you want this weekend. So I'll wrap this conference up, and thank you, all members of the panel. Thank you.
Thank you. Thank you very much. I'm signing off.